بسم الله الرحمن الرحيم. مساء الخير جميعا. يسعدني ويشرفني أن أكون ضمن البرنامج العلمي لمؤتمر طب عين شمس السنوي. وطبعا قبل ما أبتدي لازم أوجه الشكر لكل القسم وكل أعضاء القسم برئاسة الأستاذة الدكتورة لبنى عز العرب. وأشكرك يا دكتورة لبنى شكر خاص على مجهودك وعلى احترامك وعلى كل التيم اللي معاكي وعلى قد إيه يعني كنت عريقة في استقبال ضيوفك وفي الساينتفك program and everything. Now I will talk about something maybe related to pathology rather than clinician, but actually it is a problem of pathology that we meet every day, but we are overcome because we are not that clever in pathology. What I mean in my presentation is why some patients who have HER2 overexpression and prove to be positive do not respond marvelously like the other ones. And is this related to something in their HER2 overexpression? And in this particular presentation, I will not talk about HER2 low. All my presentation concentrated on score 2 and score 3 of HER2 breast cancer. Okay, so what is heterogeneity in the pathology? The two upper line was defined as either presence of HER2 positivity between 5 to 50% of the slide. So any show of HER2 positive, we put on the side, this is a HER2, but with other HER2 negative. So the pathology by immunohistochemical give you 0, 1, 2, 3, as if it is not consistent. But on the genetic level, HER2 is controlled by gene in the chromosome 17, and they have to look by microarray to the ratio of this, and this is a guideline in the ASCO-CAP definition. But all of this, how this impact my decision in the patient? When the patient is a score 3, but amplified by gene is not that consistent, it is again heterogeneous. So all those group of patients, we consider it as positive, and we are treated by dual inhibition of HER2, but they are not homogeneous. Okay. So we used to choose, or we use this slide to score 1 and 2 low HER2, and we are now talking about ultra low. But I am talking about HER2 2 score and the 3 score, and I am raising a question: is there any difference in this for the treatment outcome? So yes, HER2 heterogeneity is present, and when we started to concentrate with the pathology, we will find yes, it may range from 5 to 30% of breast cancer patients, and usually it is present in HER2 equivocal that we send for CISH or H as if we are amplifying and see the gene number, and it is usually related to hormone positive tumor. And that is bring ASCO-CAP definition on the year 2013 to revert the positivity threshold to the original more than 10% of cell neoplastic cell in immunohistochemical, but the ratio of the chromosomes to HER2 amplification must be more than 2 in the FISH test. And they are advocated to do two-step approach when scoring ISH or CISH and taking this in consideration, and this now bring us to definite HER2 positive and undefinite, but they are positive and we are treated positively. So heterogeneity on the pathological perspective, very easy and very simple, and we have to talk to the pathologist every day. It may be heterogeneous in the cluster positive, cluster negative, and it may be mosaic in between cells between each other. But is this affect the clinical implication? The story started more than 10 years ago when in a very good study, they asking themselves, there is a difference in response for patients who have a heterogeneous in immunohistochemical staining and heterogeneity in genetic staining, and they started to look for almost 96 cases. Regional heterogeneity is there. It represents 18% when in immunohistochemical and 11% when we see it from the genetic level. And they are characterized by low grade and usually score 2. Heterogeneity was consistent with shorter disease-free survival and with genetically instability may represent another clone. اصلا يا جماعه الهير2 جين ده جين مورث عندنا كلنا لكن بيحصل له mutation and they assuming that this mutation why the patient develop breast cancer may be the cause of heterogeneity. In multivariant analysis they found something that the presence of any heterogeneity in the slide of the tissue is independent prognostic factor, and this may indicate need for HER2 testing more representative. لن نكتفي بزيرو واحد score 2. We have to discuss with the pathology before we decided, and I will tell you why. Later on, the story continued in many years looking for lobular carcinoma, why they are not responding to chemotherapy like the other one, and they assuming that again, under this lobular HER2 overexpression, there may be some heterogeneity, and then this is a study that make a great change in the thinking of heterogeneity. HER2 positive tumor, and it is coming from Dana-Farber Cancer Institute, where they are looking to evaluate HER2 heterogeneity in the neoadjuvant setting in patients who will receive TDM plus pertuzumab in the neoadjuvant setting, and they found that, and this is the publication, and they are found that no pathological CR in the group of heterogeneous immunohistochemical or genetic amplification, while there is 55% versus 55% in non-heterogeneous homogeneous group with very significant value, and they started to look again to patients who attend the pathological CR in the non-heterogeneous group 67%, in heterogeneous group 25. And then they ask themselves, forget everything about genetic and do only immunohistochemical. They found that HER2 score 3 have a pathological CR more than HER2 plus 2, and this is significant again. And this is again, they forget everything when analysis exclude cases that were classified as HER2 heterogeneous and difference in pathological complete response rate immunohistochemical, either 3 or 2 with less pronounced. So they forget the heterogeneous group and they see only consistent group. They found no difference in HER2 score 3 while HER2 2. And this is very important. As if we, when doing amplification, we conceive ourselves, or we try to tell ourselves, give more anti-HER2 treatment, while this is not the fact. And this slide summarizes everything. But PCR non-heterogeneous and HER2 PCR, and then when we forget everything about heterogeneity and look only for homogeneous, there is no great difference. To emphasize to you that heterogeneity is the main cause for this non-responder. And this is a trans-Catherine trial, and you know the Catherine trial, now they are doing biomarker patients who are not attend pathological CR, we continue with either trastuzumab or TDM. And the fact here, TDM appears to improve invasive disease-free survival versus trastuzumab. We know that across most biomarker subgroup except HER2 focal expression subgroup. As if you find a patient with heterogeneity, from the early beginning, you think of more treatment or more chemotherapy, they will not respond to TDM. And here is the note from the biomarker data Catherine trial that TDM appear to improve invasive disease-free survival in all but not. What is very important this year, April 2023, the German group started to look so heterogeneity, and they collected nine studies that all calling for pathological CR as a primary endpoint. They collected 2,066 patients, all of them enter pathological PCR from 5 neoadjuvant big group, and they found that, which is very important, after a median follow-up of almost 5 years, still the effect of a HER2 heterogeneous, non-heterogeneous is independent factor. This is very important, and from now then we will not look for HER2 as a one disease. There is a great article in the breast dissecting biological heterogeneity of HER2 positive breast cancer, as if nowadays we are going to treat each HER2 in a different way. And in this dissecting biological heterogeneity, they again calling for please do tumor infiltrating lymphocyte, and usually we mention that tumor infiltrating lymphocyte in the early beginning when the patient is naive and tumor is naive may give us a very good poor prognosis. Now I almost finished my presentation, but هديلكم حاجة تحيركم زيادة. في حاجة اسمها HER3. HER3 جاية بسرعة، مش HER2 بقى هيتروجينس ونان هيتروجينس. واكتشفوا ان احنا في الاميونوهيستوكيميكال ستيننج لما كنا بنقراهم الاثنين مع بعض. فزي are telling us now as if we are reading HER2/3 but give the treatment of HER2. And they are now working hardly on the HER3 mutation and how they may benefit antibody drug conjugate, and there is many now in the market, and I put only this slide not to read it, to inform myself that there is a gush of trial to treat HER3 overexpression that may be hidden in the HER2 overexpression, and they now giving us some data in the metastatic breast carcinoma and the effects. My conclusion that heterogeneity is there. It affects the clinical outcome occurs more frequently in hormone-positive tumor. Scenario may represent a certain group of patients who may be in the very near future. Look for those group of patients to be treated by antibody drug conjugate or by dual inhibition or by less treatment. But please take care of overexpression HER3 and set with the pathology and see. For us as a clinical hint, now we have many drugs and many expensive drugs that be supported by government. So we have to do homework and we have to do patient selection. So if you find a patient score 2 and have low grade and have hormone receptor positive, those group of patients will not be that much affected by dual inhibition, and you have to give another treatment. For me هتكلم بس بالعربي دقيقة واحدة. أنا قعدت مع الصيدلية الإكلينيكية بتاعتنا على مدى من أول ما المبادرة ابتدت، ولمينا كل الحاجات اللي خدت فيسبو. الحالات اللي خدت فيسبو في النيو أدجوفنت هي بالتأكيد عندها HER2، وإحنا we are now looking for مين اللي استفاد ومين ما استفادش بناء على هي كانت HER2 score 2 we amplify it by FISH ولا هي already 3, and this will be exactly to answer the question how much heterogeneity can affect our treatment. Again and again, intratumor HER2 heterogeneity assisted by routine pathology evaluation is a strong predictor. Look for the primary tumor and then look for ISH and SISH. If this validated, this will help us to escalate or de-escalate or to choose another curative chemotherapy. And until now, thank you very much, and pray for Gaza, and please pray for Gaza, pray for Gaza, pray.
Thank you, Professor Heba. So, any question from the floor?
أنا لسه عندكم تقريبا 11 دقيقة.
Thank you, Dr. Hiba, for your interesting lecture, interesting topic. Can I ask about tumor heterogeneity? Consider in patient after neoadjuvant, can it change HER2? Can I consider it tumor heterogeneity?
This is another type of, they refer to it as clinical heterogeneity. Heterogeneity may changes like non-Hodgkin lymphoma from the primary tumor to metastatic tumor, and not from the neoadjuvant. Very difficult. يعني if you do a true cut biopsy and this may be 2, and then by biopsy you find 3, this may be a technical, but all is positive. But sometimes the positive HER2 become negative, and the negative HER2 become positive, and this is mentioned for the difference between primary tumor and secondary tumor.
يعني أنا عندي حصل معايا سيناريو patient كانت تريبل نيجاتيف ادفانسد افتر نيو ادجفنت عملنا تيست للهير2 كان بوزيتيف. هاو تريت؟ يعني انا ساعتها البيشنت كانت ستيل في ريزيدوال ديزيز، هعالجها زي الريزيدوال تريبل نيجاتيف وادي كابسايتابين، ولا اكونسيدر هير2 بوزيتيف واد الانتي هير2؟
لا، حسب الباثولوجي. as you trust the pathology, the new pathology for the patient's sake, you continue for the new pathology لان these pathological changes. لا وانا يعني لو سمحتوا لي عشان برضو الصغيرين اللي قاعدين، هو انا عايزه اوصل لايه، او انا من كتر ما قرأت الحته دي عايزه اوصل لايه. الهير 2 سكور 2 مش هيتصرف زي الهير 3 من الاول بالامينوهيستوكيميكال. امال احنا بنعمل ايه؟ احنا مره بنقرا البروتين ومره بنقرا الجين كاونت، الجين كلون، المايكرو اري. لما بنلاقي المايكرو اري عالي قوي بنقول ده خلاص الاثنين تحول ل3. على فكره هو تحول ل3 لان احنا امبليفاينج او حطينا العدسه او كده، لكن مش بالاكيد هيستفيد. وده اللي قالته كاترين ترايل، قالت ان العيانين اللي هم استفادوا ودخلوا في ريزيدوال ديزيز لسه عندهم بواقي، ما استفادوش قوي من التي دي ام، دي المجموعه الاوحش على الاطلاق. طيب اعمل ايه انا بقى لما يكون عندي كده؟ يعني this is my suggestion. طبعا الثلاثه ده لازم هياخد نيو ادجمنت وادجمنت وكده، الاثنين هراقبه قوي وهكون كين قوي ان هو مش هيدخل في ماكسيمم ريسبونس، لا اما فولو اب، لا اما بسرعه ادخل كيموثيرابي، لا اما الادويه الجديده دراج كونجيجيت طبعا if it is available.
دكتور صبري.
Thank you, Dr. Hiba, for your presentation. Nice to see this a big dilemma and help us to deeply understanding HER2 heterogeneity. As you said, we have a dilemma in the FISH technique. We have 5 categories of FISH controversy. One of them is considering after HER2 plus 2. There's 5 categories. One of them is reverted to the HER2 0 and 1, and 3 of them are still FISH positive, and one of them should be repeated. That's why I want to ask our eminent pathologist, Dr. Sanel, Dr. Mushash, about the FISH controversy, because we're in a big dilemma to give anti-HER2 for the patients with equivocal HER2 even by FISH technique. Except we repeat the FISH in another place or another pathologist.
يعني الدكتور محمد يا جماعه بيقول حاجه ظريفه جدا، بيقول اشمعنى ده اللي لازم نعيده؟ يعني في النون هودجكن ليمفوما مفيش كده، ما هو سي دي 20 بوزيتيف وكده، لكن احنا 3 بنؤمن بيه، 0 و1 بنقول له ده التقسيمه القديمه او كده، والاثنين نعيده وكأن احنا عارفين او متوقعين ان ممكن يكون هو 3 أو 2 بس احنا مش قادرين نحدد.
Another thing دكتورة هبة قبل ما دكتورة سناء تعلق على القصة دي، احنا عندنا heterogeneity between the primary and secondary. You have less HER2 positivity when taking the biopsy from liver, with higher positivity when taking the breast from the primary tumor. And that's why the HER2 only is not a single player. We have another player in the hormonal positive patients where the PIK3 mutation may modulate the HER2 positivity, or maybe modulates that the HER2 positive may be refractive to tumor. But I stick with a patient with HER2 positive too. What's further beyond FISH to confirm positivity or to exclude?
الأول بسم الله الرحمن الرحيم. يعني عايزة أقول حاجة للكلينيشن، يمكن كتير قوي ما هماش مايندد بيها. يعني حضراتكم فاكرين ان الاميونوهيستوكيمستري دون يعني ابيض واسود وما فيش فيه نقاش، وهو ده اللي بيحل الكون وهو اللي بيحل كل حاجه. الاميونوهيستوكيمستري على قد ما هو ايا كان لاي ماركر، يعني بتكلم كلام عام، على قد ما هو very helpful، وطبعا ده يعتبر ثورة في علم الباثولوجي الحقيقة، بس لازم يتاخد فيه precautions كتيرة جدا، أو نحط في الاعتبار نقط كتيرة جدا. It is very tricky. It is very very tricky. يعني هو حوالي 10 steps، كل step من دول قابلة ان يحصل فيها تكة تطلع الدنيا مختلفة تماما. يعني انا لا انسى حالة يعني مع الدكتور محمد، كانت عيانة معمول لها ER و BR بره او في احد المعامل وطلع نيجاتيف، كومبليتلي نيجاتيف، وجات لي عدتها انا طبعا يعني وبعدين عندها امل انها يعني انا اللي هحل لها الدنيا كلها. فانا يعني هي ER، وبعدين بصيت للسلايدز ER و BR نيجاتيف، مش عايزه كلام. فانا قلت اعيده لها بس عشان اقول لها انا عدت ولقيته برضه نيجاتيف واريحها لانها كانت يونج بيشنت. انا بدون ما اقصد او مش بدون ما اقصد بحب يعني هو جايبه لي بلوكات كتير، فانا بحب انقي البلوك اللي عليه تيشو كتير قوي، يعني يبقى احسن اشوف الدنيا اكتر. فعدته والله طلعت سكور 8، طلعت هايلي بوزيتيف للAR والBR. ايه اللي حصل؟ ان انا عملت على انذر بلوك. ففي يعني دي حتى يمكن مش مكتوبه في الكتب، يعني another block واحد يطلع completely negative واحد يطلع completely positive. ده one of the reasons. another reason نوع الانتي بودي، مده الانكيوبيشن، هنا مده طويله هنا مده قصيره. الاذر كيميكالز، هنا النقطه بتاعت الجهاز اللي هي بتنزل الدروب ما نزلتش على السكشن. سو ايزي، يعني انا ممكن الاقي 2 سيكشنز على السلايد، عاده احنا بنعمل كذا سيكشن، الاقي واحد كومبليتلي نيجاتيف وواحد كومبليتلي بوزيتيف. فاول ذيس بوينتس بدون ما ادخلكم في دايلما كبيره، في ماني ممكن يعني اوفر ذان 100 والله ريزونز ممكن تطلع النتيجه مختلفه تماما. فانا اي ادفايز لما تطلع حاله زي كده تو ريبيت ات ان انذر لاب، to repeat it in another lab. لقينا نفس النتيجه خلاص، انما usually بيبقى في difference. This is my main concern. استاذنكم اسال بس دكتوره هبه، هل حضرتك تتوقعي، طبعا هي مش موجوده دلوقتي في الجايد لاينز بتاع NCCN، ان از روتين باثولوجي ناسس التيومر هيتروجينيتي للHER2، على فرض انها يعني نفرض ان هي هتبقى تتحط في الجايد لاينز، في مشكله كبيره جدا جدا. هل هنقدر كباثولوجيست نؤسس التيومر هيتروجينيتي في الHER2 في النيدل بايوبسي، بالذات في النيدل بايوبسي اللي بتتاخد في مصر اللي هي بتبقى عباره عن حاجه لا تذكر؟ طب ما دي هتبقى مشكله كبيره.
اول بارت من سؤال حضرتك يا دكتوره سناء، حضرتك طبعا مشرفانا.
الصوت بعد اذنك.
حضرتك يعني استاذه عزيزه علينا. اول جزء من سؤال حضرتك هي جايه في NCC جايد لاينز، هي جايه على طول. وبما ان هم دلوقتي looking for biology to innovate a new technique for the drug، زي ما قالوا على الHER2 low، طبعا هي جايه وفيري سون. انا وريت لحضرتك ان في فيري بايلوت ترايل على مين هيتروجينس، يعني يقول لك HER2 سكور مثلا 1 بس HER3 بوزيتيف، فهي جايه وذيس از يعني era of complete revolution in the next few years. الفاين نيدل completely forbidden in breast cancer يا جماعه، وبليز don't depend on the fine needle خالص. we need
حضرتك انا اقصد، انا ما قلتش فاين نيدل، انا قلت ترو كات نيدل. لا الفاين نيدل دي سايتولوجي ما بنعملش عليها اميونو، انا بتكلم على ترو كات.
لا لازم نحترمها يا دكتوره سناء، لان هي قبل ما الجراح start to touch breast or to do any operation، يعني true cut biopsy from the breast and axilla now is a standard of care rather than frozen section. زمان كان الفروزن section is acceptable لكن بما ان في انواع من البريست never to treat it until you give new adjuvant, we still depend on the true cut from breast and axilla. مش هنقدر نهرب منه.
One comment about the TrueCut biopsy, because we have now we have dear younger colleagues about the validity of the what core needle biopsy. While core needle biopsy, it's a small biopsy, will be deeply stained with no tissue ischemia between the taking of the biopsy till the processing in the formalin. So it is ideal to prescribe ERPR receptors. While the patients doing a surgery by excisional biopsy, the tumor may be forbidden or hidden for hours without processing in the formalin and have a tissue ischemia impacting the false ERPR positive. And in our MDT, as you know, in our department, we discovered many patients have a tumor ischemia in the operation, excise the tumor in the weekend, and the tumor is kept for hours without processing. This giving us a false ERPR negative tumors. That's why in that time we had a population of triple negative disease. When you unifying the process of processing and عملنا محضر لاستلام العينات والعينات تستلم بسرعة وخدنا وايت كور جوج multiple core biopsies is highly recommended for all patients to have an accurate ERPR assessment before surgery, because it will impact the decision of to give treatment as triple negative or R positive or HER2 positive. It's my addition.
طيب هو بخصوص القصه بتاعت الهيتيروجينيتي بتاعت الهيرت نيو، هو في فاكتورز بيلت ان، يعني هي اوريدي في التيومر، وفي فاكتورز اللي احنا بنتكلم فيها اللي هي كان بي somehow controlled. واعتقد ان كل الاستاديز بتبقى اوريدي معتمده على ان اللي في ايدينا اوريدي احنا عملنا عليه كنترول. لكن هو حقيقي فيه هيتيروجينيتي، والسؤال بتاع الدكتوره سناء هلال فيري فاليد في الايديا ان هي when we are expanding all of this toll على الاسسمنت بتاع الاميونوهيستوكيمستري او حتى الفيش بالنسبه للكور نيدل بايوبسي كاتيجوري، بالنسبه للكور نيدل بايوبسي ماتيريال that at its best حتى في الوايد هتبقى representative of a very small portion of the tumor as a whole. فده بحد ذاته was it tackled ولا اكيد it was tackled، واكيد برضه الاستاديز اعتمدت على ان هو by evidence based الموضوع معمول له constraints معينه to depend on. اللي انا قريته ان هو at the end احنا بنبقى دايما بنجيب the benefit of doubt، بمعنى ان البوزيتيفيتي زي ما مشي الموضوع مع الاي ار في الستارتنج بوينت، ان البوزيتيفيتي دايما بتاخد الابر هاند عن النيجاتيفيتي، وات اني ستيج في الديزيز برضه البوزيتيفيتي ترجع تاخد الابر هاند. الاكزامبل اللي قالته الدكتوره اللي هو بتاع ان هي تبقى بعد كده اكسبريسنج الهيرتو في حين ان هي كانت انيشيالي تريبل نيجاتيف او كلام من ده. لو احنا فكرنا ان الهيتيروجينيتي دي بحد ذاتها معناها ان الانيشال درايف بتاع التيومر ما كانش هو الهيرتو بروبابلي، ان دون حاجه من الفيرذر كلونز الابجريدنج بتاع التيومر اجريشن فيتشرز اللي بدات تكتسبها السيلز مع الديفيجن. فبالتالي دون اكسبكتد ان هو فعلا السيلكتيف كيلينج اوف التيومر سيلز بوات ايفر ثيرابي ايفكت هيعمل upgrading او هيعمل flourishing للمور ريزيستنت يعني جروبس او populations زي الهيرتو اوفر اكسبريسنج. وده متهيألي برضه بيفسر القصه بتاعت الميتاستاسيس والقصه بتاعت الريزيستنس. اوريدي في كلام كتير في الليترشر على ان في تايبس معينه من الثيرابي انكلودنج الهرمونال وانكلودنج الراديشن ثيرابي بيعمل هو في حد ذاته some نيو مايكرو انفايرمنت تبدا تنهانس الهيرتو اكسبريشن. القصه بتاعت ان الريفلكشن بتاعت الاميونوهيستوكيمستري والريفلكشن بتاعت الجينز دي لانها راجعه لان لقوا ان الهيرتو بحد ذاته الاكسبريشن بتاعه maybe even more، وده اللي ريزد القصه بتاعت اللو هيرتو، انه ممكن يبقى actually what we are assessing is not equal to what's happening، لان في ماسنجر RNA ولان في الاونكوجين ولان في البروتين اكسبريشن، كل واحد فيهم ليه مالتيبلز في حقيقه الامر تحت على مستوى السيل بقى نفسها والاداء بتاعها. كل ده عمرنا ما هنقدر ان احنا نلاحق عليه اتليست بالتول بتاعه الاميونوهيستوكيمستري ولا حتى بالتول بتاعه السيش. عشان كده اتخلقت الانتيتي الجديده دي اللي هي بتاعه اللو هيرتو، اللي ان هي they can still benefit، صحيح مش من الكلاسيك ثيرابي الانتي الهيرسبتين على ما انا اعرف يعني، طبعا حضراتكم ادرى مني، بس بموداليتيز هي اوريدي موجهه لبرضه الهيرتو از ريسبتور. فايه اللي يفسر كده هو غير فكره ان في لسه في حاجات كتير بتحصل اندر يعني في مستوى تاني زي ما حضرتك كنت بتحكي بقى في التوب بتاعتك. كل ما بنكبر اللي احنا بنبص عليه كل ما بنكتشف حاجات جديده. فاي جاس ان هي دي القصه بتاعت الهيتيروجينيتي از وي كنترول بقى كل اللي احنا نقدر عليه من الايديا بتاعت البري اناليتيك فعلا فاكتورز والقصص دي كلها، والايديا بتاعت الماتيريال اللي بيتعمل عليها التستنج هاو ريلايبل ات از، لان ده نقطه ثانيه عاده ما بتغفل. يعني دايما بنبص على احنا كباثولوجيست وي ار مايندد بشكل كبير جدا، ولحد ما طبعا معظم المعامل المحترمه دلوقتي بقت تراعي القصص بتاعت البري اناليتيك، بس اللي مش بيراعى دايما هي فكره الكورنيال بايوبسي از ان اماونت، حتى ما بتتكتبش، ما بتعملش عليها دوكيومنتيشن، يعني ما بنعرفش احنا بنبص على الديسيجن اللي هنعمله احنا الماتيريال اللي جت دي كانت اوريدي ريبريزنتبل ولا لا، يعني كانت بتمثل قد ايه من التيومر نفسه.
ايوه شكرا. I agree completely with her.
Thank you, Dr. Arfa. So for the next speaker.
أستاذتي العظيمة دكتورة إيمان الشعراوي. دكتور إيمان, optimal sequencing of anti-HER2 therapy for advanced HER2 breast cancer.
Thank you, Mariam, for this very surprising and nice presentation. Dear chairpersons, dear professors and colleagues, may I start my presentation, please? So my talk today will be about optimum sequencing of anti-HER2 therapy for advanced HER2 positive breast cancer. I have no conflict of interest to disclose. My outline today is HER2 positive breast cancer, describe advanced disease, study designs, and optimum sequencing of anti-HER2 therapy. HER2 is a member of the EGFR tyrosine kinase family. It includes 4 transmembrane receptor proteins, HER1, HER2, HER3, and HER4. Receptor activation will stimulate cell proliferation, migration, invasion, and survival. Overexpression or amplification of HER2 is found in approximately 20% of all breast cancers. We usually recommend HER2 testing by a validated immunohistochemistry assay. If the result is 3, it's HER2 positive. If the result is 2, we recommend a validated dual probe ISH assay. If amplified, it will be HER2 positive. Advanced HER2 disease includes inoperable locoregional recurrent or metastatic disease. It does not include isolated local, regional, or locoregional disease because the goal is curative. In that situation, the goal is radical treatment. But in advanced HER2 positive disease, the goal is palliative to delay the progression of disease, prolong survival, and minimize treatment-associated toxicity. The factors for choosing therapy are site and extent of metastasis, performance status, previous treatments, symptoms, comorbidities, and patient preferences. When a metastasis is suspected, we usually recommend a biopsy from the initial metastatic site to assess if it is second primary or a metastatic disease, and to evaluate the hormone receptors HER2 status, because discordance can occur in 10% to 15% of patients. Metastatic workup is done either by conventional CTs and bone scan or FDG PET-CT imaging. Recently, fluoroestradiol PET-CT can be used as a metastatic workup in case of estrogen receptor positive lesions. And we also recommend tumor markers for monitoring of the disease. There is a higher frequency of brain metastasis in HER2 positive disease and an increased frequency or prevalence of bone metastasis in triple positive disease. So, when do we change our practice? We change our practice only based on clinical trials or meta-analysis and systematic reviews. Medical research includes primary research or secondary research. Primary research includes basic research, clinical trials, observational studies. We never change our practice based on basic research or observational studies. Secondary research includes meta-analysis and systematic reviews. So we change our practice based on clinical trials or meta-analysis and systematic reviews. We don't change our practice based on phase 1 and phase 2 trials. Phase 1 trials are only conducted to identify the maximum tolerated dose for subsequent phase 2 studies. So when we demonstrate a phase 1 study, this is not a practice-changing trial. Phase 2 trial is conducted to provide effectiveness data for a subsequent phase 3 study. So we don't change our practice based on phase 2. We only change our practice based on a high-quality phase 3 trial. And what do we mean by high-quality phase 3 trial? It's experimental against current standard. Because standards changes. So when we do critical appraisal, it should be experimental against current standard, which is called the control arm. Phase 3 trials are randomized controlled trials, and they are the gold standard of clinical research. They change the practice of oncology because the results can be generalized. The results can be generalized because we do randomization. Randomization is done to minimize bias, to balance between baseline known and unknown prognostic factors between different arms. What are the endpoints? Overall survival is the gold standard for demonstrating a clinical benefit. But other endpoints can be used to demonstrate clinical benefit as progression-free survival and time to progression. Why we use these? So that we can speed up trial completion. But the interpretation of clinical benefit is difficult. Why? Many reasons. One of them is that progression-free survival is not a surrogate endpoint for overall survival. That means that an improvement in this endpoint may not be translated into improvement in overall survival. And we will see this in multiple phase 3 trials 1 minute ahead. So what is the scope of this lecture? Since the theme of the conference is the art of decision making, and the lecture title is Optimum Sequencing of Anti-HER2 Therapy for Advanced HER2 Positive Breast Cancer, this lecture will tackle only high-quality cancer care. So resource allocation, prioritization based on strategic planning, cost effectiveness, future research including phase 1 and phase 2 trials are outside the scope of this lecture. And not only this, we will not tackle the answer for the how question and the answer for the where question. Why? Because if we tackle the answer of the how question, the clinical pharmacy input should be included. And if we tackle the answer for the where question, the access to therapy should be included. So the scope of this lecture will be the answer of 3 questions only. What are the what? These are the types of therapy used. The why, the phase 3 trials which showed benefit outweighing risks, and the when, which is the optimal sequencing. So the answer for what is that we will use trastuzumab and pertuzumab, which are monoclonal antibodies that target the extracellular domain of HER2. TDM1, which is an antibody-drug conjugate, neratinib, which is an irreversible pan-HER2 TKI, trastuzumab deruxtecan, which is an anti-HER2 antibody-drug conjugate characterized by a high drug-antibody ratio, about 8, and a bystander killing effect. And lastly, the margetuximab, which is a monoclonal antibody that targets HER2 and enhances both the innate and the adaptive immunity. So what are the phase 3 trials that showed benefit exceeded risks? In the first line setting, we have 2 phase 3 trials, the Marianne trial and the Cleopatra trial. The Marianne trial did not show an improvement for adding pertuzumab to TDM1 in progression-free survival. So, Marianne trial cannot change our practice in the first-line setting. And we have the Cleopatra trial, which showed an improvement in both progression-free survival and overall survival. And the improvement in overall survival was maintained up to 8 years. So this trial is practice-changing trial. The design was to randomize patients between docetaxel, trastuzumab, and pertuzumab versus docetaxel, trastuzumab, and placebo. Nearly half of the patients received prior adjuvant or neoadjuvant therapy. Nearly a quarter of the patients received prior adjuvant endocrine therapy. 11% received prior trastuzumab. Both progression-free survival and overall survival improved. Progression-free survival improved from 12.4 to 18.7 months. The hazard ratio was 0.69. The median overall survival improved from 40.8 to 57.1 months. The hazard ratio is 0.69. And at 8 years, the progression-free survival improved from 10% to 16%, and the overall survival improved from 23% to 37%. In the subgroup analysis, all patients benefited from the addition of pertuzumab, except patients with non-visceral metastasis. But remind you, this is a subgroup analysis. The patients were not randomized for visceral metastasis or non-visceral metastasis at the first randomization. This is only subgroup analysis. We don't change practice on subgroup analysis. It's only a basis for a next study. The adverse events, the most common adverse events were alopecia, followed by diarrhea, then fatigue. Grade 3 or more adverse events were found in the form of neutropenia, febrile neutropenia, leukopenia, and diarrhea. Exposure to studied treatment and cardiac tolerability were comparable in both groups. The adverse events after discontinuation of docetaxel was in the form of diarrhea in the group receiving dual anti-HER2 blockade. So the conclusion was that addition of pertuzumab led to an improvement of 6.1 months in progression-free survival and 16.3 months in overall survival. At 8 years, overall survival was improved from 23% to 37%, and the long-term safety and cardiac safety profiles of pertuzumab, trastuzumab, and docetaxel were maintained. So the combination of trastuzumab, pertuzumab, and docetaxel is considered an optimal first-line therapy. What about the second-line setting? In the second line setting, we have two phase 3 trials, the Emilia trial and the Destiny Breast 03 trial. The Emilia trial compared the TDM1 versus lapitinib plus capecitabine, and it showed a benefit in both progression-free survival and overall survival. TDM1 was an optimum second-line therapy until TDXD replaced it. In the Destiny Breast 03 trial, TDXD showed an improvement in progression-free survival from 7.2 months to 25.1 months. This is not 2 months or 3 months or 4 months. This is 7.2 months to 25.1 months. So the optimum second-line therapy now is TDXD, based on the Destiny Breast 03 trial. The primary endpoint was progression-free survival, and as we said, it improved from 7.2 months to 25.1 months, and the hazard ratio is 0.26. The overall survival data are immature. What about the patient subgroups who benefited from TDXD? All subgroups benefited from TDXD. Those with hormone receptor positive and negative, those who received pertuzumab or not. Nearly 60% received pertuzumab and trastuzumab in the first line. Those with visceral disease or not, and those with stable brain metastasis. With patients with stable brain metastasis had an improvement of progression-free survival from 3 months to 15 months. The most common adverse events associated with treatment discontinuation were interstitial lung disease and pneumonitis in case of TDXD, and thrombocytopenia in case of TDM1, and there were no grade 4 or 5 events of drug-related interstitial lung disease or pneumonitis. So the conclusions were, TDXD showed a statistically significant and clinically meaningful progression-free survival benefit with a 72% reduction in risk of progression for TDXD. The progression-free survival for patients with stable brain metastasis at baseline improved from 3 months to 15 months, and safety profile were comparable between the two groups. So TDXD is recommended as an optimum second line for patients who have experienced progression after trastuzumab and taxane or after pertuzumab, trastuzumab and taxane. In the third line setting, we have 3 phase 3 trials: the SOPHIA trial, the NALA trial, and the TERESA trial. The SOPHIA trial showed only progression-free survival improvement of 1 month, from 4.9 months to 5.8 months only. Overall survival didn't improve with margetuximab plus chemotherapy versus trastuzumab with chemotherapy. So this is the least favorable choice for a third-line therapy. What about NALA trial? NALA trial compared neratinib plus capecitabine versus lapitinib plus capecitabine. It showed no improvement in overall survival. The TERESA trial showed improvement in overall survival, 15.8 months versus 22.7 months. But the standard or the control arm was physician choice of therapy. So it contained multiple confounders. It can't be used as a standard, although the overall survival improved. So we have 3 choices for third line setting: TDM1 or neratinib plus capecitabine or margetuximab plus chemotherapy, in that order. But there is no optimum only therapy for the third line therapy. This is the TERESA trial, showed improvement of progression-free survival from 3.3 months to 6.2 months, and improvement in overall survival from 15.8 months to 22.7 months, and the hazard ratio is 0.68. In the NALA trial, there was improvement in progression-free survival only. There was no improvement in overall survival, but the CNS progression-free survival improved from 8.3 months to 12.4 months, and the hazard ratio was 0.62. In the SOPHIA trial, as we said, there were no improvement in overall survival, but the progression-free survival improved from 4.4 to 5.7 months, only 1 month improvement. So the optimum sequencing of anti-HER2 therapy for advanced HER2-positive breast cancer will be docetaxel plus trastuzumab plus pertuzumab based on the Cleopatra trial. For the second line, TDXD based on the Destiny Breast 03, and for the third line and beyond, TDM1 or neratinib plus capecitabine or margetuximab plus chemotherapy. Thank you.
Thank you, Dr. Iman, for your great lecture. Any question? Any question? Okay.
So maybe breast cancer patient is long survival, so I just want to ask about the fourth line. Is there any chance for the fourth line?
Fourth line, yes, you can choose between the three, yes, with TGM1 or neratinib plus capecitabine or margetuximab. These are for the third line or beyond. You can choose either of them because nobody knows. Nobody knows which is that.
Dr. Aman, thank you for this informative talk. Do you think that the treatments received in the adjuvant setting make difference if the patient received either pertuzumab or even nowadays TDM1 in the adjuvant setting? Does this sequence differ?
Until now, the Cleopatra is the best if the patient received trastuzumab only. In the Destiny Breast 03, patients received, nearly 60% received prior trastuzumab and pertuzumab. So we don't have the answer if the patient received TDM1 in adjuvant setting. We don't have a phase 3 trial telling us what to do. We don't know yet. If the patient received TDM1 in the adjuvant setting for a residual disease, for example, we don't know what to do because we don't have a phase 3 trial, and that's why I said I am only limiting my lecture to phase 3 trials only. So we don't know. We don't know what to do with the patient who received TDM1 because we don't have a phase 3 trial answering this question. The answer is to conduct a phase 3 trial for these patients.
Thank you, Dr. Let's introduce our next speaker, Professor Dr. Azza Darwish. She will talk about HER2-low breast cancer biology and the challenges of treatment.
Good evening. First, I would like to thank my professors for the kind invitation. It's my honor to give a presentation at the same session with Dr. Hiba Zawahi and Dr. Iman Sha'rawi. My talk is about HER2-low breast cancer, biology and challenges of treatment. Actually, HER2 is expressed on nearly all normal tissue in the body: breast, skin, lung, GU, and urinary tract. Normal cells express few HER2 receptors on their surface, while in malignant breast cancer, HER2 expression may range from thousands to millions of receptors per cell. Similarly, all breast cancer subtypes express some degree of HER2 receptor, and this is variable. The expression and the detection of HER2 expression differ according to the tissue analyzed and also the sensitivity of the HER2 assay used. As you all know, HER2 positive breast cancer presents from 15 to 20%, while 80% of the patients are collectively termed as HER2 negative, and this definition has been for 2 decades or more. This definition because they lack the amplification of the HER2 gene, and despite lacking of the HER2 gene amplification, most of these tumors do have some expression of the HER2 receptor, and this can be identified by the immunohistochemistry test. This is the ASCO-CAP definition. As you see, this is the group of patients with HER2-negative disease. Actually, it is a heterogeneous group of patients. Some are scored 2+, some 1+, and some 0. They are heterogeneous. Actually, patients with a score 2+ or 1+, they express 100,000 of HER2 receptors on their surface. That's why they are termed now HER2 low. And HER2 negative term is to define patient with a score 0. And if we go deeply in this group of patients who are termed HER2 negative now, we will find that even this group of patients are heterogeneous because they contain some cells that do not express HER2 receptor at all, and some cells express hundreds or thousands of receptors. So this group is now subclassified into HER2 0 without any expression of HER2, or HER2 ultra low, which is an intermediate group between HER2 0 and HER2 1+. So now the patients are defined either HER2 positive, HER2 negative, or HER2 low, and in the future we'll have the term HER2 ultra low also. And the classification now is that 15 to 20% of the patients are HER2 positive, 50% of the patients HER2 low, 30 to 40% only of the patients are HER2 negative, and they contain the HER2 ultra low in them. So 50% of our patients are defined as HER2 low. Do the expression of the HER2 low positivity differ according to the expression of the hormone receptor? Yes. 60% of the patients who are hormone receptor positive, they are HER2 low, while in the triple negative, only 40% of the patients are HER2 low. This work from Dana-Farber showed that the HER2 low positivity increases progressively with the increase in the expression of the hormone receptor. Patients with hormone receptor negative, let's say the triple negative, 40% of them are HER2 low, as I mentioned. Patients with ER low from 1 to 9%, 46% of them are HER2 low. While patients with a strong estrogen receptor expression, more than 90%, 60% of them are HER2 low. So the expression of HER2 low increases with the increase in the estrogen receptor expression. Is HER2 low positivity prognostic? Actually, this question is not answered till now. We have a lot of trials, retrospective data showing that HER2 low positivity is not prognostic. But of course, we need further trials. Could this group of patients benefit from HER2 blockade? We have an old trial, the NSABP trial. This trial randomized patients with early breast cancer who are HER2 low, 1+ or 2+ negative, to receive the standard adjuvant chemotherapy with or without Herceptin. And what they found, adding trastuzumab for patients with HER2 low in the adjuvant setting did not improve any progression-free survival or overall survival. Pertuzumab also was tested in the advanced HER2 low breast cancer and showed no benefit. What about our oldest ADC, the TDM1, also tested in advanced HER2 low positive breast cancer and showed little activity. So one, to define a patient as having HER2 low on the archival blocks of the primary tumor or in the metastatic, the new biopsy of the metastatic setting. When to say the patient is HER2 low. As you all know, HER2 amplification and overexpression is stable. It retained its expression with time. HER2, expressed 3, retained its expression with time. With almost less than 10% of the patient may show variation in the HER2 expression between the primary and the metastatic setting. This is not the case in the HER2 low. HER2 low is variable. Patient may present with a primary tumor that is HER2 low, and when develop metastasis, it turns to be HER2 0, and the opposite way around. So HER2 low can change. So on which biopsy you will depend, on the primary tumor or in the new biopsy from the metastatic setting. Actually, Alice Pratt presented a good presentation in La San Antonio, and he found that based on the DESTINY-04, patients with HER2 low positivity, either on the primary tumor or in the subsequent biopsies from the metastatic site, if they show HER2 low at any time, they will benefit from trastuzumab deruxtecan. So practically, patients will be termed HER2 low if he showed any biopsy at any time having HER2 low expression. And if we apply this definition, we will find that at the metastatic setting, 80% of the patient will be defined as HER2 low. So just to summarize, HER2 low is not a prognostic factor, no benefit from HER2 blockade, but we have the ADC. They showed encouraging efficacy in this group of patients. Why? Because the ADC do not depend on blocking the receptor and the oncogenic pathway, but they depend on delivery of the cytotoxic chemotherapy to the cancer cell. Our oldest ADC, the T-DM1, as you all know, when it's compared with T-DXd, they have a lot of differences. The payload different, the ratio between the antibody drug is different, but all of these not important. The most important thing is the linker. The linker is cleavable in the T-DXd, but not cleavable in the T-DM1, and this is the cause for the bystander effect of the T-DXd. This summarizes how T-DXd works. T-DXd bind to the HER2 receptor, and then it will be internalized inside the malignant cell. Then the payload will be released inside the cell to kill the cell. At this step, the T-DM1 stops its action. While in the T-DXd, because the payload is permeable, it can permeate the cell membrane and pass to the surrounding cells, even if they do not express any HER2 receptor, and this is the bystander effect. T-DXd was tested in phase 1 and 2 trial, and it shows activity in HER2-low advanced breast cancer, even if they are heavily pretreated. And that's why we have the phase 3 trial, the DESTINY-04 trial. As you all know, it's the phase 3 multicenter trial. It randomized patients with advanced breast cancer who are HER2-low, either hormone receptor positive or hormone receptor negative, to receive T-DXd or treatment of physician choice, which was capecitabine, eribulin, gemcitabine, or paclitaxel. In this trial, 80% were hormone receptor positive and 20% were hormone receptor negative. The primary endpoint was progression-free survival in the hormone receptor positive patient. The two groups were quite balanced. Most of the patients in this trial were heavily pretreated. The median number of treatments were 3. Most of the patients received 1 or 2 prior lines of chemotherapy, and the hormone receptor subgroup of patients were considered endocrine refractory. The results were amazing. Significant improvement in the progression-free survival in the hormone receptor positive subgroup, with almost doubling of the progression-free survival from 5 months to 10 months, with a hazard ratio of 0.5. And this result was replicated when we look at the overall population. Overall survival in the hormone receptor positive is also significantly increased by 6 months. So it is statistically significant and clinically meaningful. And the results are also consistent when we look to the overall population. And because of these positive of the cases in the study, and again, there was a statistically significant improvement in the progression-free survival and overall survival with a similar hazard ratio to what's seen in the hormone receptor positive. Although if you look at the numbers, the progression-free survival and the overall survival, they are much less than the patient who is hormone receptor positive, because this would be the triple negative, you already have more prognosis, but still the magnitude of benefit seen with transformative scan is maintained when we look at this group of patients. So the question, is the activity of T-DXd different according to the hormone receptor status? Actually, no. T-DXd is beneficial regardless of the hormone receptor status. When we look at the subgroup analysis, all the subgroup patients benefit from T-DXd. Even patients who has either IGC 1 plus or 2 plus, both benefited with the same magnitude, and patients who received several lines of prior treatment. As you all know, the toxicity of T-DXd, the main toxicity is nausea, fatigability, and unfortunately, alopecia. It's present in 40% of the patients. And remember, most of the patients with HER2 are hormone receptor positive. They used to take hormonal therapy without alopecia. It's good to give them a very potent drug, but to remind them that alopecia is a toxicity that's well seen in this drug. And we can't talk about T-DXd without mentioning ILD.
Actually, 12% of the patients experience any rate of ILD, mostly grade 1 and grade 2. But the updated data of the SMO4 showed that 4 patients developed grade 5 ILD. Serious adverse events, we have to be vigilant, we have to keep an eye on this side effect. Treatment of HER2 is not the next yellow. We have several drugs. We have these 2 couple drugs emerging and showing good response rate in heavily pretreated HER2 low breast cancer, but the trials are still ongoing. But recently, we have the data from the TROPICS trial. What TROPICS trial is assessing the sacituzumab govitecan, another ADC, in patients with hormone receptor positive, HER2 low advanced breast cancer, compared to treatment position choice of single agent chemotherapy. This trial showed significant improvement in progression-free survival and in overall survival. This trial in patient is HER2 negative, and when they look to the subgroup of patients with HER2 low, again we found that sacituzumab govitecan benefit patients if they are HER2 low, HER2 0, and on the low overall population. So another drug significantly improved the progression-free survival and overall survival compared to chemotherapy in patients with HER2 low. As regards the actual there is an ongoing trial. We have all know the DAISY trial, and now we have the phase 3 STEMO6 testing the beneficial effect of toxicity in HER2 ultra low. We are waiting the result of this trial. So the take-home message: half of breast cancer cases are HER2 low. HER2 low positivity do not have distinct prognosis, no clinical benefit for using anti-HER2 treatment, but the ADC of course has activity. The rate of HER2 low increases with increasing the level of estrogen receptor expression. TXT in the first HER2 target therapy to demonstrate improved efficacy in patients with HER2 low advanced breast cancer. STEMO4 establishes TXT as the new standard for patients with HER2 low. And sacituzumab govitecan is an emerging new drug that also shows significant efficacy in HER2 low breast cancer. Thank you.